My name is Abdou Elhendy. I'm a clinical associate professor of medicine at the University of Wisconsin, Madison, Wisconsin, and a practicing cardiologist at Marshfield Clinic, Marshfield, Wisconsin. I did present a lecture today on non-invasive cardiac imaging in hypertensive patients for the diagnosis of coronary artery disease. This presentation was a part of the 21st Congress on Heart Disease organized by International Academy of Cardiology. Hypertension is a major risk factor for coronary artery disease and its complications. It is estimated that over 70 million adult individuals are affected by hypertension in the United States alone, and the prevalence worldwide is 20 to 30%. Hypertension is associated with increased risk of cardiovascular disease, particularly in patients who have additional risk factors and in patients with markedly elevated blood pressure. Therefore, identification of an accurate method for evaluation of coronary artery disease in these patients is warranted. Performing coronary angiography is not justifiable in every patient because of associated risk. There are many challenges in evaluation of coronary artery disease in hypertensive patients. One challenge is the presence of baseline electrocardiographic abnormalities, even in absence of left ventricular hypertrophy, which can impair the accuracy of stress electrocardiography in these patients. Other challenges include the presence of left ventricular hypertrophy and demand ischemia in absence of coronary artery disease. Wall motion abnormalities and left ventricular dysfunction can exist in absence of coronary artery disease. Hypertensive response can lead to a stress test termination and can lead to a false positive response as well. I discussed multiple modalities in evaluation of coronary artery disease. Stress echocardiography is widely used. It is considered rather cheaper than other modalities without the risk of irradiation. Its diagnostic accuracy is higher than electrocardiography, and it has also shown to provide incremental prognostic value in patients with known or suspected coronary artery disease. The disadvantages include suboptimal quality in 10 to 20% of patients, which can be improved by administration of contrast. You can also use contrast to assess myocardial perfusion in these patients. Other disadvantages include the submaximal sensitivity in patients with low heart rate and the false positive results in case of a hypertensive response. I also discussed myocardial perfusion imaging with radionuclide isotopes. It's widely used to assess coronary artery disease with a very acceptable sensitivity and specificity. It has a long track record and accurate risk assessment of patients and determining cardiovascular prognosis. Its disadvantages include the presence of imaging artifacts occasionally in some patients, rendering the test technically difficult, and exposure to irradiation. In patients who have difficult imaging quality, various options exist. One of them is cardiac magnetic resonance imaging. You can perform that test with dobutamine stress to watch wall motion abnormalities, or with dipyridamole stress to detect myocardial perfusion abnormalities. Pooled data from many studies have shown that the accuracy of these tests is significantly higher than the accuracy of other modalities such as myocardial perfusion scintigraphy and stress echocardiography. However, these tests are not widely available, and they may incur more risk. PET imaging can assess metabolism, function, and perfusion, and can differentiate between pathological and physiological left ventricular hypertrophy. Finally, anatomical imaging include coronary CT scoring. Hypertensive patients have higher incidence and larger severity of coronary artery calcifications. These are associated with increased mortality. Screening may be advised in patients who are in asymptomatic patients who are considered to be at high risk. Finally, coronary CT angiography is a very variable technique for diagnosis of coronary artery disease. It has a very high negative predictive value. It can virtually eliminate the possibility of coronary artery disease if there is no abnormality detected with that study. It's usually indicated in patients who have equivocal or inconclusive stress test, or if you have a stress test that is positive in a low-risk patient and you're suspecting that it might be a false positive test. The disadvantages include it's not feasible in patients who have severe coronary artery calcifications. Also, it entails some irradiation, about 8 to 12 millisievert, unless a low-dose protocol is used in occasional patients. The test also is shown to provide significant prognostic information. In summary, there are various non-invasive imaging modalities to address the presence and severity of coronary artery disease in hypertensive patients, and the use of a particular technique should be individualized based on anticipation of performance of a particular test.